Hello everyone and welcome to this episode of Let's Talk Forensic Psychology. We are very pleased and very grateful to have Dr. Lorraine Higham on this episode joining us today. Welcome, Lorraine. Lorraine is a consultant clinical psychologist working currently as a lead psychologist for the Learning Disability and Autism Division at St Andrews Healthcare. Lorraine has a specialism working with people who have autism spectrum disorder and has published on the topic, looking at clinical and criminal profiles of those who have committed internet offences and have ASD, obsessive compulsive disorder and ASD, and internet and fantasy versus reality experiences with people who have autism. Lorraine currently works with females with autism spectrum disorder and learning disability, and we're really looking forward to hearing and learning more about Lorraine's experiences and expertise in this area. So thank you so much for joining us. Lorraine, we always start our episodes with asking people how they got into the job, like what route that people took into psychology. So please, may you tell us all about how you got to be who you are?
I guess starts back with A-levels, choosing psychology, really enjoying it, and then thinking I didn't really know what else to do at university, so did psychology. I've always been interested in people, and I think psychology just felt a natural degree for me to do. And then whilst completing the degree, just became more and more interested in becoming an actual psychologist. However, I wasn't completely sure, so I did my undergraduate in psychology at Sussex University. And then I went on to Cardiff University for a year to do a master's in criminology and criminal justice. And then realising actually I think I preferred a bit more of the patient route as opposed to just the research and teaching side, decided to pursue a clinical psychology route. So did 2 years as a assistant psychologist. 1 year was in a community mental health team that we had a DBT service running in, so I was able to support with that. And 1 was in a learning disability community team in Birmingham that covered quite a broad area of Birmingham, supported people with a learning disability and autism in the community where they were showing some concerns and risk behaviours, but not enough to warrant detention in a secure hospital. So after completing those, I then got on the doctorate at Leeds University, which took 3 years, and then here I am now. So started at St Andrews in 2010 and have remained at St Andrews ever since.
Oh, nice. Yeah. I love how you say you got on the doctorate like it was just really easy, like, oh yeah, I just got it's a really difficult thing to get onto, isn't it? The getting into the doctorate.
Yeah, no, it can be competitive, but I think I had one of the key things they look for is the amount of experience you have before applying. And I should have said I did an HCA role for a year as well, where I worked in a crisis team and on a acute ward as well at the same time. So I had that experience, then 2 years as an AP, and then got on the doctorate course. So had a good amount of experience and about, so to speak, when applying. So
really useful to know, because a lot of people want to know how to get onto it. So I'm glad you added that bit on, because that's often a route we recommend people do the HCA role, and then we started in the prison service taking assistant psychologists on again. We haven't taken them for years, but the NHS have usually taken them. But it's very competitive to get into it.
I think doing the HCA role is a really good way in as well, into learning about what the service is like and seeing how a psychology team work. Because lots of people they'll say to us on other recordings that we've done, or when we've done like career talks and things, about how on earth, how do I get into doing psychology, like how do I do it? And actually sometimes that, even getting in like the AP roles or the volunteer roles, they're so competitive in themselves. It's about stripping it back a little bit further than that. HCA roles, we've talked about, like you can go to help out in like visit centres and prison service settings, and really kind of like think about what it is that you can be learning in these roles, that you would also use those same skills as a psychologist. And I think doing a HCA role is a really good example of that.
Yeah, and I loved it. I learned an awful lot from that position, particularly working on an acute ward where you're kind of faced with people who are acutely mentally unwell, and you often don't see that in other situations, even in secure care at times, because that's the reason for the short admissions in and out. So I learned an awful lot, and being a part of the crisis team. And I also learned how not to be a psychologist, because we used to get one that would turn up, see a patient, that would disappear without any feedback, and then sometimes there were difficulties afterwards and nobody knew what had happened in the session. So I always thought, when I become a psychologist, I'm going to ensure I always feed back to the team so that people have an understanding of of the patient and their needs and what was discussed in case support is needed afterwards. So it was good for my learning in that sense as well.
So you have a specialism in working with people with autism. Could you tell us firstly what autism is? How would you recognise it or diagnose it?
Yeah, so autism is a developmental disorder. So it's something you're born with. You can't catch it, and it's not something you'd develop later on in early teens or anything. So the age at which it gets diagnosed varies significantly. So some people with autism may display a lot of difficulties from a young age and therefore get diagnoses quite early on in their childhood. Although some of that depends on the waiting time, because that's quite lengthy at the minute. Whereas other people, it may be that there's been some concerns or underlying anxiety, but it's never presented as problematic. But then the transition to secondary school has proved too much because there's a change of routine, there's a lot more pressure, expectation, social groups change. And that can then result in the individuals feeling quite overwhelmed. And then actually, when you look back, when they're seeking support, you can see that the kind of the developmental delay was there, but they're just masked it well enough to kind of get through the early years. And actually now it's become more difficult as they've got older.
And do you think the masking happens more with males or females, or is there any difference in that?
I think I'd probably say females more than males, from my experience. I don't know what the research would say about this. I think there is growing evidence, though, that it's underdiagnosed in the female population. And I think a lot of that is because they are generally better. Females are better at masking. And I think sometimes as well, there is the differences in that special interests may not get picked up on as much in females, because it may be that their special interest is clothing or makeup. So things that are socially acceptable, but may just be beyond what their peers may do, but not enough to warrant concerns. Whereas with males, to be slightly stereotypical, though, it may be trains or it may be vehicles and things that actually is beyond, quite clearly beyond what other individuals of that age would kind of be interested in.
One of the things that I have struggled to get my head around is how we assess for autism. There feels to be lots of little compartments of what we need to do to make a diagnosis of autism. Could you explain a little bit in simple terms for our listeners around how we assess for someone who may or may not have autism spectrum disorder?
Yeah. So the standard kind of approach that we take to diagnosis is to complete an assessment with the individual who people feel may have autism. So the standard one is the ADOS. So that gets completed with the individual and is a series of questions and activities for them to complete that is quite informative to the clinician to assess for it. And then there should always be a developmental history as well. And there's various ones that are that people use. There's the DISCO, there's the ADIR, or just a really good detailed developmental history that is ASD informed. So there's various ones that different individual places have and use. So the developmental history and the assessment with the patient is key, really, because the developmental bit, especially if you've got patients that are very complex and where there may be other diagnoses or where there may have been trauma in the past, the developmental history gives you more information than perhaps what the ADOS would pick up on. So the ADOS at times isn't as good at discriminating between, say, autism and schizophrenia, or indeed patients that have been in secure care for a very long time who haven't had access to friends and support networks for a long period of time or had the opportunity to live independently. So it's not as good in that sense at times for patients that do have severe and enduring mental health problems. But in the community, it is a useful tool, but the developmental history is really key to kind of see that before the age of 3 and then around the age of 5 years going upwards, that there were difficulties, even if it was minor difficulties like they were a bit fussy with their food, for textures, with sleep, overly attached or disinterested in attachment, difficulties, lots of tantrums. So just lots of little bits. There's no specific thing to look out for. It's just that there were some differences in how they were as a younger child compared to perhaps peers of their age that don't end up with a diagnosis.
One of the things we talk about quite often on here is sort of the use of labels and how people like to be referred to. And I've read recently about not referring to it as a disorder, because if it's a developmental thing, it's not necessarily disorder, and some people don't find it a problem. That's just the way they think or the way they developed. And also we think about whether we call people with autism, because we tend to try and use person first language, or whether you'd call someone autistic, and would that be then describing somebody completely by an aspect of them? So what's the sort of general consensus on that? Is there one, or does people vary?
I think it varies. I don't think there is one. And I think a lot of it comes to personal preference. I think some people are very happy and almost proud to say they're autistic, and that is a part of who they are, whereas other people just see it as an aspect of them, but not as a whole. Some individuals with autism refer to themselves as Aspies, other as neurodivergent. So there's just different languages, and I think it's whatever the people with the diagnosis of autistic spectrum disorder have, whatever they feel comfortable with, that they use.
Yeah. So I was wondering what the links are then between having autism and offending.
So I guess, first of all, to say, just because you've got autism, it does not mean that you're likely to offend. There is a slight increase in kind of the population of those with autistic spectrum disorder and offending, but it doesn't naturally mean that you're going to become an offender if you have autism at all. So, and again, there's various papers out there with that have kind of talked about this, and I think some of the key bits are the social naivety at times that can come with autism, and that difficulty to kind of read other people, to know social norms, to understand what's appropriate for a situation or what somebody may be asking them to do. So I had one patient, for example, who was a friend, someone he thought was a friend, that got him to do something that was actually illegal, but because they thought they were their friend, they didn't think they'd asked them to do something bad. So therefore did it, and then got into a lot of trouble with it. So that kind of naivety around friendships, and well, they're my friend, they would therefore never get me to do something bad. And then they do end up doing something that gets them into trouble. And then when they did get into trouble, the friend that they thought they had was nowhere to be seen. So that's one of the difficulties. I think obsessional interests at times can get people into difficulties. So, you know, people hacking into various sites because they're interested in something, but actually that becomes illegal, or again just doing something that is beyond what is legal, going on to, you know, having particular obsessions and therefore breaking and entering into places, or going onto land that isn't theirs in order to fulfill certain obsessions and interests, stalking somebody that they've become obsessed with. So that can be problematic. I think difficulties with change can cause problems. It can become very overwhelming for them and distressed, and they can become agitated and can then lead to perhaps an incident happening. We've talked a bit about misunderstanding social cues. And again, you know, a lot of people with autistic spectrum disorder struggle with eye contact. They struggle to read body language. They struggle to read emotions and to pick up on things. So can end up in difficulties and may misread somebody's interactions, think it's something more than they want it to be. So could end up trying to, you know, kiss somebody that actually isn't interested at all in that, but because they've misread it, they end up doing something and then get into trouble for that. And I guess that rigid adherence to rules as well, and coming annoyed if people break rules. So various kind of things kind of around those key themes are kind of what I would say are some of the difficulties. But by no means, as I say, having autism does not make you become an offender.
In my experience of working with people with autism, of lately at least, I've been working with people who have autism and have committed a terrorist offence or internet offences. And I was thinking a lot recently about the links between ASD and internet offending. And I also know that you have published a paper on such topics. So I was wondering if you could share some of your key findings from that and encourage us to think a little bit about the links some more.
Yeah, I mean, I guess it was very much a pilot paper, in the sense that this area hadn't been explored a huge amount before, and we had a lot of data from the patient groups that we have in the hospital, and actually of the number that we had, there was only relatively few that at that time had committed internet offences. I think it'd be really interesting to repeat it now, because I think internet is much more prevalent than it was even a few years ago. And I think one of the things that also came out of it was that at times some of the internet offending that we knew happened in some of the patients wasn't actually recorded as an offence, because actually they'd been, say, arrested or got into trouble for something else, and it was only kind of through things they'd said or other people had commented upon that the internet offending actually came out. So it was also felt that it wasn't that more research is needed around that. So I think the main kind of bits were that, as I say, there wasn't a huge amount of people that had committed internet offences. Of those that we did study, the majority of those, it was sexual offending, either both contact and non-contact sexual offending, and a lot of it was regards to paedophilia as well. So when we explored that a bit more, it seemed to be linked around, again, a lot of individuals with autistic spectrum disorder. Well, again, I'm not saying a lot. Some individuals with autistic spectrum disorder struggle with interaction. They struggle to form relationships. Pornography is now much more available online than it ever was. Before we had the internet, you'd be going to a shop and you'd be limited in what you could get. The internet now is a massive resource, with access to a whole load of pornography. And I think what, again, we know about pornography, it can become addictive. And the patients that I've worked with have talked about starting out with mainstream pornography and then needing more and more and more to get the same response. And some of them ended up going into child pornography because that was kind of where their need then to get the same response led them. So I think some of it is that it was to get that kind of fix that the initial pornography had given them. I think for others of the offenders, what we found was that they couldn't form relationships. Children gave them a safety net, in a sense, particularly with the contact offences as well, where there were contact offences as well as internet offences, because children are more vulnerable. They're more easy to manipulate to a degree. So the internet fueled in a few individuals, we felt, their desire for children and actually led them more likely to offend. So I think it was a few bits around the internet offending, but the contact and non-contact sex offending was the main bit. And again, that difficulty to have relationships, so therefore having a needs met. And for some of them as well, it's just photos. I'm not doing any harm, that it's already been committed. And for some people it wasn't real. So I don't think we included all of this in the paper, but these were additional bits that we kind of found out along the way, but perhaps weren't warranted enough without further support to kind of put in the paper. But again, I'd really like to pick up that study again and see where we are now and what we'd find.
So with the people that you looked at, would they, or maybe something you didn't ask them, but if they were accessing images of child sexual abuse, would they see that as a sort of shameful thing, or that was wrong? I mean, you mentioned about saying their pictures. I mean, I've worked with people who said that, who haven't got autism, they were there anyway, and I didn't commit the offences. But would they sort of feel the shame or the guilt that people generally would feel when they get arrested for that, for instance, when they've accessed images of child abuse?
I think that's a really difficult question to answer, because I think there was a mixed response, and I'm also thinking about other patients that I work with that have committed offences towards children, and I think some of the time there is a lack of awareness about the offence that they've committed, and again, I think there is that difference between it being a contact and non-contact, and it is very much so they don't see it as a crime scene. Some of it see it as, well, it was there, oh, it's not real, or I haven't caused the harm, so don't see it. I've had some patients challenge me about, well, if it was in a different country, there are no laws around the age at which you can have sexual relationships with children, so therefore we should bring these laws in place in the UK, and really struggle with the reasons as to why that's not okay. So I think it's a real mixed kind of picture as to why, to those that do express remorse and recognise that it wasn't okay, but still pursued that route.
Some of the people I've assessed can't, when we show them images of children at various ages, can't judge the difference in ages. So often can't, throughout the spectrum of ages, not just children, but adults as well. They find it, they just haven't, I've assessed several people that just not even be able to, they sort of try and judge by what else is in the picture, how old the person was, rather than by looking at their face or their sort of the way they're standing or anything like that. Some people find that really, I don't know if that's a facet maybe of learning disability or of autism. Again, that lack of sort of understanding the differences?
I think it's both. And I think, you know, it's really difficult nowadays, isn't it? When you turn on the TV and you see girls on there and you think, oh, they're in their, you know, their early 20s, and they turn out to be 14, 15 years old. So I think that's a risk in general, in that girls are portraying themselves to be a lot older than they actually are. So I think it certainly is there with some of the patients. They'll say, well, I didn't realise she was that age. But again, I don't think some of them, the patients, questioned either that. And because I think sometimes they are very naive around relationships and about what that involves. And as I said, misinterpreting, say, what the other person is actually wanting to do, and whether they are just being friendly or wanting more. So I think some of it is also around kind of that misinterpretation and not seeing age. I think sometimes they don't see age, if that makes sense. They just see whether they're attracted or think people are attracted to them. But again, I don't want to make sweeping statements. This is just my own experience of working with this population.
I was completing an assessment of sexual knowledge on someone the other day who has a diagnosis of ASD. And I was thinking, I don't think this is the results of this. I don't think they are taking into account diagnoses and how lacking, how some of the tools that we so commonly use in non-ASD populations aren't adapted. Like we so regularly adapt for LD, for learning disabilities, but how often are we adapting for ASD population too? And I was thinking about how much we're lacking in that area.
Yeah, I think a lot of the what we're finding more and more is a lot of the, you know, assessments that we use in for lots of things, they're not adapted to the autistic population, and that can be problematic at times because it doesn't pick up on some of the challenges that autism can present with. And so we are trying to adapt as we go, but with the assessment still having that validity, but asking additional questions to confirm further kind of views and supports on top of that, because it is a difficulty.
Another thing I was also thinking about was how often people we maybe over label, and some of the traits that people have with autism. You mentioned it lightly earlier, thinking about schizophrenia, but how with personality disorder too, how often people are presenting with autistic traits, and then we're also diagnosing with various personality disorders rather than just thinking about autism. I know that's something you're quite passionate about. I wondered if you had any thoughts on that.
Yeah, I think it's really important to get diagnoses correct. I think a lot of women are misdiagnosed at the minute with personality disorders and schizophrenia. I think there's also probably misdiagnosis of those where they've been given a diagnosis of autism, and actually it's due to kind of developmental trauma in their early years, which is presenting in a similar way to autism. So I think there's a lot more research to be done in kind of the assessment side of things in general, to ensure that we are getting correct diagnoses as to whether it is autism, to whether it is trauma, to whether it is a personality disorder, whether it is a combination. But I think at the minute we're quite crude in a sense in the assessments that we have to distinguish between those. And I think it depends a lot on the clinician's experience and expertise, and also kind of the service as well that they're in, as to how people perceive those difficulties. Because sometimes, you know, particularly in secure care, a service is required, and sometimes it feels that labels have been given to a patient to get them into a certain service at some point in their time, rather than it actually being the correct label for them to get them the support they need.
And those assessments very often aren't redone sometime later, when people, you know, have had their needs met and maybe not showing the same symptoms or presenting with the same problems at all.
And I think the other challenge we have at times is that sometimes individuals come into our service with a very clear diagnosis of autism, and then people start to question it, and it needs redoing. And I think that also has its own concerns with it, because what we know about autism is you can't cure autism, but what we know is that people can develop the social skills, and they can mask and they can compensate for the areas where they've had difficulties in the past. So can seem much more skilled, I guess, than perhaps they once were, but that doesn't warrant the removal of assessment. So sometimes as well, I found myself in situations saying, no, they've got a diagnosis from childhood, it's a very clear, thorough assessment. We need to leave that and now think about what the additional difficulties are. Can autism still account for that, or do we need further support? But I think also it's whether, I always think diagnoses are helpful, but only if you need sometimes help with it, or unless you as an individual don't feel you understand yourself. I'm not somebody who would willingly just give diagnoses to people for the sake of it. I think, there are lots of people in society that have autistic traits and are possibly on the autistic spectrum, but don't have diagnoses because actually they're functioning incredibly well in society. They have relationships, children, successful jobs, etc., and they're fine. So I think it can be helpful when support is needed, but it is then about getting the correct label for that to get the support.
So you've talked about working with women with learning difficulties and disability and with autism. Is there sort of an overlap in those areas?
Yeah, so several of our patients do have a comorbid diagnosis of autism and learning disability. And I guess part of the reason I've raised also about kind of the trauma as well is that all of our females sadly have a trauma history. And so it is about now trying to unpick those diagnoses to check if they still fit for autism, or whether it is more trauma related. I think for some of the individuals as well with learning disability, it's possibly circumstances that have led to them having a learning disability, rather than, if they'd been raised in a different environment with support and schooling and a happy home life, they probably wouldn't have a diagnosis of learning disability. So they're a complex group of ladies with the comorbid diagnoses, but there are a lot of factors from their early years and histories that also complicate it further.
So I think so often when we've had people on, or we've been talking about certain topics, we tend to talk about them from a sort of male perspective, like a male forensic population perspective. And I think it's something for us as the Let's Talk team to think a little bit more about how this applies to females and getting people on that have had experience of females and working with females. So it's great to have you on having that experience. And perhaps like a question that we could ask is, like, what do you enjoy about working with females? Because there's lots of myths and rumours. You hear lots of people saying, God, I'd never want to work with females, and give a myriad of reasons. But what is it that you enjoy about working with the female population?
I think it's incredibly rewarding. I think you are able to form good attachments to them. I think particularly when they've had really challenging upbringings, you are able to form good therapeutic relationships with them, which is a lovely thing to be able to do. I also like, I guess the downside for them is their insecure care. I like that, because though in the sense that it gives me time to work with them. We don't have 8 sessions and then they're moving on. We can work with them to really help them with the difficulties that they have, so that then when they do move on, they're much better equipped to manage the difficulties that they've had. So it can be incredibly challenging. And yeah, I've heard lots of times people say, oh, I couldn't work with women. But for me, it's also incredibly the reward overrides the challenges. And when you see progress and people progressing and going onto grounds leave and then community leave, and then they move on, it's really rewarding to see that. And I think, yeah, there is, having worked with males and with females, there's a difference about it that, I mean, it's nice for both when they move on, but I don't know, there's something different with the females. I think there's a lot more emotions, but I guess whilst that can also be the challenge, it also brings more with it as well, I think.
Nice. And how do women sort of fare in the literature about how we're represented? Because I do remember, the first time I heard about, as it was Asperger's then, they talked about it was generally males that had it and very few females, and it seems to be really balanced, seems to be changing now. I mean, are they sort of represented more in the literature, or is it still that there's more males than females with autism?
I think that they are underrepresented still. I think the evidence is suggesting now that there is still the ratio is still more males to females, but that reduces if you add in a learning disability. And and then it equals out more. But I think there is the recognition now that it's probably more similar. I can't think of the exact ratio off the top of my head, but there are more females, but it's the under assessment of females that aren't being picked up. And then, as I said, often with females, it can be that it presents in teenage years, and the challenges may be low mood and self-harm, and that's what then gets picked up. And then it's whether that's diagnosed correctly as autism or as an emerging personality disorder or depression or something else. So that's when I think it is being missed at times, because it's being seen as other things rather than actually, let's look back. Oh, actually, they've always had anxiety. They've always had their routines, or yeah, they were really obsessed and interested in that, but that doesn't get picked up on. So I think, yeah, it's with females, it can get missed, and therefore I think more research is required to kind of look into that more. And I think we need assessment measures that are more specific to females as well, because it does present differently, and I don't think the current measures are sensitive enough to pick up on it. I think there are a few that are being developed and are being used, but nowhere near as widely as, say, the ADOS is, or the ADIR and the DISCO. So I think we need to improve a bit some of the assessment measures.
It's a cycle that really does need breaking, isn't it? Because if you think about an example of a female who may have had autism but diagnosed with something else, they get placed into a service. If they come in trouble with the law, they might get placed in a service that isn't autism specialist, and then the consequences of that might be a lot of behavioural challenges, because they're finding they're overstimulated, or many other reasons that are happening. They then become labelled as challenging. You might get more diagnoses added on, personality disorders, interventions that aren't specialised, and then it becomes a real cycle that people can get stuck in hospital or stuck in the prison service and actually not being offered the help that they need.
Yeah, and I think, if you think of the services, the majority of autism services are for males. I don't think there is one that's purely for women. Yeah. And I think that just shows again that the difference. And I'm not saying we would have as many females needing beds, but I think it's naive to think that there aren't substantially more patients with autism that, as we say, are misplaced in different services. There is a high percentage, as my understanding, with eating disorders of ladies with autism. So again, it's whether they're being placed into different services, which may be appropriate if they've got eating disorders, but again, it's blurring the picture of the autism, and actually how many females have the autism diagnosis as well.
Yeah, I saw a documentary where a unit where women were sent with eating disorders, but actually they all then got a diagnosis of autism. So you think, it's what the association was. And people talk about it, not necessarily that they just don't want to eat, but it's a sensory feeling of the taste or the smell or the feel in your mouth or the unpredictability of food, all those sorts of things that we wouldn't necessarily understand. We would think, well, they've just being picky about their food, but actually it's actually often about that hearing other people eat around them, having too much choice of a menu. There's things like that. They're actually overwhelming them rather than the food itself that's the problem. So then they just go to something really predictable, like cereals or something they can eat very easily and know what's going to be like.
Yeah. There are a lot of challenges around food for all those reasons, but I do think it does get picked up in different ways, and sometimes the sensory component of just not feeling hungry either, and that need to therefore eat. They're just, well, I wasn't hungry, so I'm not going to eat, rather than actually, well, I need to eat. So it just varies a lot in individuals with autism.
What would be useful for people to, if they're looking for ideas of research, what would it be a good idea for them to do with the female population, do you think?
Oh, that's a good question. I think there's lots of things. I think we need to do a lot more research into the impact of trauma on individuals with autistic spectrum disorder, and also the impact of psychosis with autism as well, because I think there is particularly, again, I guess I'm from a very skewed service in that I work in secure care, so we have a very specific group of ladies, that the impact, but psychosis being present as well, and it not being treated and individuals not responding in the same way as people perhaps with schizophrenia would. So they get a diagnosis of schizophrenia, but actually the antipsychotics don't work. And actually you look, they've got extensive trauma histories, and actually how that impacts on the trauma and the psychosis. So I think there's a lot of research needed there. I think just the general understanding around kind of the restrictions that individuals with autism have, the sensory overload that can just get too much, and that need to withdraw from people, which people can see, perceive in the community as odd and, difficult to manage. But also we see on the wards as well, where they just get overwhelmed and they just need that space in a quiet room to just regulate themselves again. So yeah, I think there's a lot to be done in terms of research with ladies to get more of an understanding about how it impacts on them specifically, rather than just looking at the research that's been conducted on males with autism and kind of assuming that they experience it in exactly the same way.
I don't know why we've got this far in the episode when we haven't acknowledged that it's Autism Acceptance Week. So we probably should have done that at the beginning, but it is Autism Acceptance Week on the 2nd of April to the 8th of April. And Autism Acceptance Week is all, isn't it? It's kind of the name is as it is on the tin, is about accepting autism diagnoses for people and raising awareness. So to end, what do you think that we could be doing more to raise awareness and to offer support to those we work with?
I think there's still stigma around it. So I think some of it is still helping people overcome the stigma, to talk more openly and freely about it. Autism, people see it as a really negative thing at times. Autism can actually have real positives, because in the same way it can bring the challenges, that ability to hone in on things, to have a special interest, can be phenomenal. Individuals like Elon Musk have come out as having a diagnosis of, I think his was Asperger's, we don't use that term now, but of having an autistic spectrum disorder, and look at what he's achieved. And that is probably due to the autism being that focus, that intensity. So it's not, I think it is to create a healthy awareness of autism as well, that whilst it may present challenges, it can also bring brilliance as well. And actually there's a lot to be celebrated within the diagnosis of autism. And when I'm assessing people, it's pulling out those positives as well, that whilst there are challenges, what can we see that actually is a real strength of the autism as well, because it does bring a lot. So from my point of view, for autism awareness, talk more openly about it. Again, I guess like with the stigma around mental health, let's kind of keep working on reducing the stigma. But actually, yeah, let's look for what the strengths are within it as well as what people perceive the negatives to be.
Yeah. I mean, I was given a lecture recently, and I balked at the term as it being a mental disorder, I suppose, given that it's a developmental disorder. And I suppose I was sort of questioning in this lecture, in 10 years' time, would we think, why is this in the DSM? This is a developmental disorder. Why would it be seen as a mental disorder? And I suppose that's what I was trying to think, how to put that into words. Because again, the stigma that draws by being in the DSM, as opposed to just being, in a sort of a general diagnosis of things that how people develop differently.
And I think, yeah, completely agree with that. I think particularly the fact, you can't medicate autism. We can prescribe medication for the anxiety, for the low mood and things, but obviously you can't treat autism. So I guess for me, in some ways, that also, why is it linked in with mental health in that sense? Because it isn't a mental health problem. It is a developmental disorder. It brings with it mental health difficulties at times, but not for everybody. So there are lots of people with autism, as we've said, functioning in society that don't have mental health problems, or don't have difficulties enough to warrant intervention. So yeah, it will be, I fully think in, I don't know whether it's 10, 20 or 50 years time, there'll be a test that you can have, because there is so much variation still. And I guess in my head, I'm also not clear whether it is all autism is the same cause, if that makes sense, or if there are different factors that cause similar presentation of symptoms that at the minute we are clumping together as autism, but whether they as kind of research and understanding advances, it will be more specific. Well, these are the difficulties associated with this because of, I don't know, this chromosome, or these are the difficulties associated because of this chromosome, and whether it will be that specific as a genetic thing or not. But I fully expect in the future we will have a very different understanding of autism and how it's seen and how it's treated, in a sense, whether that's through therapy or through some medication as well, with some aspects of the challenges like the anxiety and depression.
Because of course lots of people get anxiety and depression and don't have autism, so it's how they're put all together, isn't it, really, that overlap of symptoms. Yes, it's difficult to sort of think about people being all of those things put together onto someone, or somebody listening who has autism, or maybe just recently got the diagnosis, thinking, is this my trajectory? So being aware that, lots of people, as you say, don't have any of these problems. But I suppose we work with a very skewed sample, don't we, of people who come into our services because they've got an overlap of the different aspects of it.
Yeah, and you can look upon the internet. There's numerous famous people out there with diagnoses of autism who are doing phenomenally well in their career and are very successful. So I always point to people in that direction as well, that whilst it can feel quite scary and overwhelming because of the negative connotations linked with the diagnosis at times, it actually isn't something that will hold you back necessarily, but will actually can bring strengths and enable you to excel in some ways. So
I guess maybe that's something we could really think about for Autism Acceptance Week, that there's lots of positive things about it. It doesn't necessarily need to be a negative thing.
Yeah, I was just thinking then the questions around what is the links between ASD and offending. I mean, obviously our channel is about forensic psychology. That's a question that we would ask, but why also did we not ask what are the links between autism and being a phenomenal person, or what are the positives about having autism? Like, I guess if we're raising awareness and it's about accepting autism, we should be talking about the positives too. So thank you for doing that.
But also not going to the other extreme, because I've seen people sort of standing up against, I'm not a superhero because I've got autism or neurodivergence in any way. I don't wear a cape, I just have this, and it's not a superpower. I think people sort of are over sort of trying to help people to think, there's not something terrible wrong with you, you've just got this different way of thinking. And then people go too far and they say, well, no, we haven't got a superpower, we just think differently to you. So it's always sort of that happy medium, isn't it?
Yeah, and I guess that kind of goes back to what we're saying in terms of if it's not presenting as problematic, you don't need the diagnosis. Because I think for me, a diagnosis is unless somebody has struggled throughout life and wants to understand themselves, for me, a diagnosis is about getting some support and help. If you don't need that, you don't need necessarily the diagnosis. And it is just about, even people without diagnosis think differently, they act differently, they have different perceptions about things. We don't need to label each and every one of those. We just accept, people as being different, don't we? And that's why we're friends with some people and not with others, because we've got more shared commonalities with some people than with other people. So I think, it is about just having that awareness that it can bring strengths. It does have its challenges at times as well, but we don't need to label everybody as having autism unless, from my point of view, it's presenting as difficulty and they need to start accessing support for services, and then it is needed as a diagnosis to progress and get support.
Thank you so much for coming on. It's great to be in line with Autism Acceptance Week and raising awareness, and I think you've done that beautifully, so thank you. That means that all there is left to say to close this episode is let's talk forensic psychology.